This is Pick Your Poison. I'm Dr. JP, ER doctor, toxicologist, and unapologetic lover of all things poison. I have some huge news I can't wait to share with you. Pick Your Poison was nominated for Best Science Podcast at the New York City Podcast Awards. I'm beyond honored, and this happened because of you, listening, sharing, and cheering the show on. Thanks so much for being part of this journey and for helping to make it possible. All right, imagine a fever that doesn't break with acetaminophen, i.e. Tylenol or paracetamol, a toxin that leaves you trapped inside your own body. Want to know what your doctor is really thinking when you tell them you take a round white pill? Stay right here to find out. This is an interactive story. Survival isn't guaranteed. Will our patient live or die? It's up to you and the choices you make. Button up your white coat and let's get started. It's time to pick your poison. Tonight we begin in the emergency department. The intern presents the case of a 67-year-old man with an altered mental status. The patient was found wandering on the highway. You picture it, a man muttering to himself, bathed in the harsh glow of headlights. Cars roaring past. He's skimming the edge of danger as he lurches along on the shoulder. A startled driver swerves past and calls 911 to get him out of danger before it's too late. The intern says the patient is mildly confused. He's talking about the CIA monitoring radio waves in his head and the government injecting trackers into his bloodstream. He is, however, oriented to his name, the year, and the month, as well as the fact that he's in the hospital. The patient complains of a mild cough, a runny nose, and pain in his feet for several weeks. Vital signs are as follows: temperature 100.9 Fahrenheit or 38.2 Celsius, heart rate 120/80, respiratory rate 18, and pulse ox 100% on room air. The intern says other than the mental status, as previously noted, the patient's exam is unremarkable. His heart and lungs are normal, there's no abdominal tenderness, and he has good strength in all of his extremities. His feet have good circulation, there's no sign of infection. The intern ordered lab work, including a complete blood count and a Chem 7. Given the mild elevation in the patient's temperature, he ordered a urinalysis, a chest x-ray, and a flu and COVID swab. You agree with this initial workup and go in to examine the patient yourself. The patient appears disheveled and unkempt. He's likely undomiciled. He says he has a history of bipolar disease. He denies other past medical history. He has been taking his medicine, he says, a round white pill. Question number 1. This medicine is most likely A, acetaminophen, i.e. Tylenol or paracetamol, B, a multivitamin, C, a psychiatric medicine, or D, who the heck knows? The answer here is D, who the heck knows? It's anybody's guess what the white pill is. If you answered this question, then you got it right, because any of the above can be round and white. Every manufacturer of medicines can make them into whatever size and shape they want, especially once they become generic. Viagra, for example, is famously the little blue pill, but generic forms can be white and round, just like every other medicine. We'll give our patient a pass in this case since he's obviously confused, but I hear this description of meds on a daily basis from patients without any mental status issues. We medical professionals do not know which round white pill you're on, so please take a picture of your medicines and put it in your phone, put a list in your wallet or something so this important information is available when you need it. The patient's mental status is as described by the intern. He carries on a regular conversation with you, but is easily distracted by external stimuli and is at the same time conversing with someone who's obviously not there. Mentally agreeing with the intern's excellent history and physical exam, you leave the room. There's no past medical history listed in the patient's electronic medical record. Whether this means he's never been to your hospital before or if he's been registered under a different medical record is anybody's guess. It's a little difficult to sort out what's going on here without any collateral information from family members or correlation with the past medical history, such as prior ED visits, diagnoses, or medicines. The patient says he's heard voices for years, so this isn't new onset psychosis. You can have psychosis with bipolar disease, though this seems much more like schizophrenia. It's unclear at this moment. Is this ongoing underlying disease or an acute exacerbation? Further complicating the clinical picture is the low-grade fever, which could be a cold or something more serious. The workup is a bit of a fishing expedition. You agree with the intern's plan and wait for the results. The patient's labs come back with a mild white blood cell count and a lactate elevation. The white blood cell count usually means inflammation or infection, but mild elevations are very nonspecific. These days, we're all concerned about lactate levels because we use them as an indicator of sepsis and septic shock. Therefore, in this case, since it's elevated, I would presume that the patient has an infection, treat with antibiotics and IV fluids, and admit the patient to the hospital for further workup and evaluation. That said, infection isn't the only thing causing an elevated lactate. It can be from seizures, from chronic alcohol use. Some medicines like antiretrovirals and metformin can cause it. Albuterol, which we use in breathing treatments, liver failure, renal failure, or even something as simple as the nurse keeping the tourniquet on too long while trying to find a vein to draw blood. 2 days later, the hospitalist consults you for a toxicology consult on an inpatient who's become increasingly agitated. You go up to the room and recognize this man as the same patient you admitted 2 days ago. The medicine resident reviews the hospital course with you. The inpatient team looked for signs of infection, but thus far haven't found anything. The patient's chest x-ray, urine, and blood cultures were negative. His lactate, which was only mildly elevated to begin with, resolved rapidly. They're not sure why it had bumped up, but they don't think it's particularly significant at this point. However, despite the improvement in his labs, the patient became increasingly agitated. Currently, his vitals are as follows. Temperature 101.5 Fahrenheit or 38.6 Celsius. Heart rate 115 beats per minute. Blood pressure 120/80. Respiratory rate 20. And oxygen saturation 100% on room air. So let's see, his temperature is going up despite his lactate getting better and the hospital team not finding any source of infection. They've continued to treat him with antibiotics. His heart rate is elevated, probably due to the fever in this case, as they've given him plenty of IV hydration. The resident tells you they did some digging and found a different chart in the electronic medical record under the patient's name but with a different spelling. The old chart confirmed your suspicion that the patient does have schizophrenia. He's been in and out of psychiatric hospitals several times, but no other past medical history was noted. He does smoke tobacco, but there's no report of illicit substance use. The team restarted his prior regimen of psychiatric medicine in the hope that it would reduce the hallucinations. The chart showed he was treated with intramuscular injections of Haldol or haloperidol, an antipsychotic, long-acting depot injections. These last for about a month at a time. The team didn't see recent doses, so they started the patient on oral Haldol in the hopes of improving his mental status. Despite this, he's gotten worse, prompting the toxicology consult. Worried you might have missed something serious in the emergency department, you mentally review your ED workup, but don't remember any red flags or obvious misses. The inpatient resident continues, we did a spinal tap for rising fever and worsening mental status. It was normal, a few of the cultures are still pending, but there's no evidence of encephalitis or meningitis thus far. This brings us to question number 2. When patients abruptly worsen in the hospital on the second or third day after admission, a common complication is A. Alcohol withdrawal, B. A medication error, C. Underlying psychiatric disease. The answer is A. When patients worsen after 2 days in the hospital, alcohol withdrawal is always at the top of the list. Any history of alcohol, you ask? Not that we know of, he says. A classic presentation is a patient not forthcoming about the amount of alcohol, admitted to the hospital for surgery, and then 2 or 3 days later abruptly becomes worse due to withdrawal. Is that what's happening here? Well, worsening confusion and altered mental status with fever and a rapid heart rate absolutely could be caused by alcohol withdrawal. We need some more information though, so you go to the bedside for an exam. Your first thought stepping into the room is that he looks a lot worse than he did in the emergency department. He doesn't acknowledge you, and he's mumbling something about the CIA. You say hi, reintroduce yourself, and ask if he remembers you from downstairs. He doesn't respond. His skin is sweaty. You listen to his heart and lungs, and other than the rapid heart rate, it's normal. You ask him to stick out his tongue to check for fasciculations caused by alcohol withdrawal. He mumbles again, so you use a tongue depressor to look inside. No fasciculations, and he doesn't have a tremor in his extremities either. Alcohol withdrawal doesn't seem very likely at this point. The inpatient team has done a thorough workup for infection, and it's thus far negative. Why did they call you for a toxicology consult? To consider causes of toxicologic hyperthermia. We've talked about this in prior episodes. Alcohol withdrawal is on the list, but doesn't quite fit here as I said. There's no history of alcohol use, and he doesn't have a tremor. Malignant hyperthermia we've talked about, also a genetic disease of the muscles. This happens when patients are exposed to things like anesthetic gases or paralytics. They develop hyperthermia and muscle rigidity. Doesn't really fit here either. What about a sympathomimetic toxidrome due to cocaine or meth? Certainly easy to find drugs when you're living on the street. The patient's presentation in the emergency department didn't fit. No tachycardia or hypertension at that point. And his skin exam was normal, not sweaty like it is now. So unless he was taking cocaine or meth while in the hospital, and it should be noted that this is definitely possible, it really doesn't fit either. His current diaphoresis, i.e. the sweatiness, is probably due to the fever. Also, he's not hypertensive, so I don't think that this is a sympathomimetic toxidrome. Could it be anticholinergic toxicity? We've said before that this can cause fever and an altered mental status, but it usually causes dry skin. In addition, he hasn't been exposed to anticholinergic medicines, so unless he took a surreptitious overdose of Benadryl, i.e. diphenhydramine, while in the hospital, again, it really doesn't fit. We talked about uncouplers, where the cell, instead of generating energy and ATP, loses it as heat. Aspirin and dinitrophenol are examples. These are fascinating drugs. Listen to the malignant heat episode for more, but again, doesn't quite fit here. This leaves us with two causes of hyperthermia we definitely need to consider closely: serotonin syndrome and neuroleptic malignant syndrome, also called NMS. Both are caused by drugs used to treat psychiatric disorders. Both look fairly similar with a few key distinctions. So first, let's talk about the similarities. Both serotonin syndrome and NMS cause fever, altered mental status, and muscle changes. But they're caused by different mechanisms, different drugs, and the muscle changes are distinctly different as well. Serotonin syndrome is caused by things elevating serotonin, thus the name, obviously. So SSRIs, for example, selective serotonin reuptake inhibitors like Prozac and other similar drugs. You ask the intern if they treated the patient with anything other than Haldol. He says only the antibiotics. There is one antibiotic that can cause serotonin syndrome, and that's linezolid. It's a really big gun antibiotic for resistant infections. The resident confirms the patient hasn't gotten this. Neuroleptic malignant syndrome is also caused by psychiatric drugs, but rather than SSRIs, it's caused by antipsychotics. And these drugs primarily affect dopamine rather than serotonin, so NMS is a problem with dopamine levels. One of the key distinguishing features between serotonin syndrome and NMS is the muscle exam. And that's question number 3. Neuroleptic malignant syndrome causes A. lead pipe rigidity, B. flaccid paralysis, or C. hyperreflexia and clonus. This is a tough one if you're not a medical professional, but if you've been listening to prior episodes, you just might know the answer. The answer is A. NMS classically causes lead pipe rigidity, meaning the patient's muscles are stiff and difficult to move. Flaccid paralysis is caused by things like botulism and paralytics. Hyperreflexia and clonus are muscle changes caused by serotonin syndrome. This is where the muscles are essentially hyperactive. So if you tap a reflex hammer on the patient's knee, their leg will jerk back and forth several times instead of once. All right, so back to our patient. We know he takes psychiatric medicines. Could this be serotonin syndrome or NMS? A good way to start is with his reflexes. You're not a neurologist or a medical student, so you don't carry a reflex hammer, but you use your stethoscope to tap his knee. His leg barely moves in response, meaning his reflexes are hyporeflexic. So this isn't likely to be serotonin syndrome. You ask the patient to raise his arm. He doesn't respond. You raise it up off the bed. It's hard to move, like he's trying to resist you, but it's clear he's actually not paying you any attention. He's still looking the other way and mumbling about the CIA. You move his hand back and forth at the elbow, feeling stiff resistance in the joint. This is actually lead pipe rigidity, so-called because apparently, and I've never tried this myself, but this is what it feels like to bend a lead pipe. There's no test we can do to tell the difference between NMS and serotonin syndrome, so we have to go on history of exposure as well as the physical exam. I'd be pretty confident this is NMS because the patient has been on Haldol and his physical exam with fever, altered mental status, and lead pipe rigidity fits. You ask the resident about the patient's labs. He says basically normal except for an elevated CK. CK, or creatine kinase, is an enzyme elevated with muscle damage, so this also goes along with NMS. Why? The muscle rigidity is so severe it leads to muscle breakdown, and that's reflected in the elevated CK. It can actually cause rhabdomyolysis and ultimately kidney failure. So this is confirmatory for NMS, in my opinion, making this a pretty clear case. However, I have to say in real life it can be tougher to tell NMS from serotonin syndrome when patients are taking both antipsychotics and SSRIs, not uncommon combo as you can imagine. Another diagnosis further complicating matters is catatonia. In severe catatonia, patients can be comatose with high fever, rigid extremities, and even rhabdo. These patients are often on antipsychotics for obvious reasons. I've had a number of cases in my career, as I'm sure have many experienced toxicologists, psychiatrists, and intensivists, where it is extremely difficult to tell NMS from catatonia. There is only one saving grace, and that's that while treatment is variable for these overlapping diagnoses, there is one thing that can treat all three, and that's benzodiazepines, every toxicologist's favorite drug. The resident asks what benzo to give. Anyone is fine. I often start with lorazepam, brand name Ativan, because it's quick and easy to obtain in most hospitals. I would definitely give it intravenously because our patient is pretty sick rather than orally. Do we expect an immediate response once we get it? Well, this is another difficult question. Sometimes, yes. I once had a patient rigid and stiff in bed. He'd been completely unresponsive for several days. I told the medicine resident to give a benzo, and she called me 2 hours later, shocked, saying the patient was now awake, sitting up and talking. That said, the dose can be difficult to titrate because the side effect of benzodiazepines is sedation and altered mental status. Therefore, we usually start with smaller doses and titrate up to avoid the side effects, but it can be hard to know when you give a low dose if the patient isn't responding because they need a higher dose, or if it's because you're going down the wrong path with the wrong diagnosis. This is where we get into the art rather than the science of medicine. My approach in general is if the patient doesn't get worse with a low dose, then I usually take that as a good sign to give more. Different benzodiazepines have different times to onset. IV lorazepam generally starts to work in several minutes. The resident orders a dose, and you sit down to write a consult note and wait to see what happens in the meantime. About 30 minutes later, the resident says the patient's temperature is now down to 101.0. His muscles are still stiff, but he is at least trying to move a little bit on his own. You agree it seems to be helping and recommend slowly titrating the dose up. You also tell the intern to stop the haloperidol. All right, so what's actually happening to our patient and why is it being caused by antipsychotics? Neuroleptic malignant syndrome is caused by a lack of dopamine. You need a dopamine to move, essentially, and if you don't have enough, you can't move. As its name suggests, it's caused by antipsychotics, or neuroleptics, their old name. Most of these are dopamine antagonists, reducing dopamine levels in the body. NMS can also be caused by withdrawal from drugs that increase dopamine, as seen in patients with Parkinson's disease. We use L-DOPA, i.e. levodopa, a precursor to dopamine, to treat Parkinson's. And if a patient suddenly stops taking L-DOPA, then they can also develop neuroleptic malignant syndrome due to dopamine absence. Some have suggested this should be called Parkinson's hyperthermia to distinguish the two, but the mechanism is essentially the same. We don't know exactly what causes NMS. It's believed to be due to a lack of dopamine secondary to D2 receptor blockade. It's thought that this results in abnormal thermoregulation in the brain and increased calcium release in the muscles, leading to rigidity. NMS is rare to begin with and much rarer than it used to be. It's estimated to occur in 0.02 to 3% of patients taking antipsychotics, and it's far less common with newer atypical antipsychotics rather than traditional first-generation ones like haloperidol. Today, atypicals are preferred for treatment in most cases due to better side effect profiles. Because NMS is so rare, it's important for us in the medical profession to discuss it. It's one of those diagnoses like pulmonary embolus. If you don't think about it, you'll never diagnose it. The other difference we didn't discuss between NMS and serotonin syndrome is the time to onset. Serotonin syndrome happens hours after exposure to elevated serotonin, for example, if the patient takes an overdose or if they take 2 strong serotonergic drugs at the same time. NMS, however, occurs over days to weeks. It is sometimes associated with an increased dose of a dopaminergic drug, but strangely, it can really occur at any time if a patient is taking one. All right, so I want to know, did we miss NMS in the emergency department with our patient? It's a good question, difficult to say. It's possible his mild temperature elevation at that time was the beginning of NMS, but it's difficult to know if he really had an altered mental status or if that was just his baseline mental status due to schizophrenia. Always, NMS is a diagnosis of exclusion as there's no test. Without a doubt, we needed to treat for and rule out infection first. Further confusing the clinical picture is the tendency of NMS to wax and wane in severity. Maybe we missed it, or maybe he did have a mild viral infection, and the NMS was actually from restarting his Haldol. It's pretty much impossible to say for certain either way. NMS is a true emergency. It was first described in 1956, and original mortality estimates were as high as 30%. I mean, that's shockingly high. In modern times, it's estimated the mortality rate is about 16% if associated with first-generation antipsychotics, which is still pretty high. Fortunately, it's less severe with second-generation atypical antipsychotics, with the mortality rate around 3%. What causes the fatalities? It's the complications of hyperthermia, including multisystem organ failure, cardiac arrhythmias, and also renal failure, which I mentioned earlier. Interestingly, it has a hereditary component that's not well understood, but if family members have ever had NMS, that's a risk factor for development. Benzodiazepines are an excellent first-line treatment. We do have other treatments. What are they? That's question number 4. A. Diphenhydramine or Benadryl. B. Bromocriptine. C. Acetaminophen, i.e. Tylenol or paracetamol. The answer is B. Bromocriptine. First and foremost in the treatment of NMS is withdrawal of the exposure. So stop the medicine causing it or restart L-DOPA if it's been withdrawn. The second step is benzos, as we discussed. Third, risks and benefits of other medicines can be considered. We do have a medicine that increases dopamine. It's a dopamine agonist called bromocriptine. It can be taken only orally or via gastric tube. There's no IV preparation. and it can worsen underlying psychiatric illness, so you have to be cautious, especially if you've just stopped antipsychotics in a patient with psychiatric illness. Another medicine called dantrolene has been used. This is the antidote for malignant hyperthermia. In that case, it reduces muscle rigidity by counteracting calcium inside the muscles. There are a few case reports suggesting dantrolene might be useful for NMS, although this is far from definitively proven. Dantrolene causes muscle weakness, so if you have a ventilated patient you're trying to extubate, this could be an issue. Do antipyretics, i.e. anti-fever agents like Tylenol work? That's question number 5. A, yes. B, no. Actually, antipyretics don't help at all in NMS. The patients can and do get life-threatening hyperthermia with temperatures above 105 Fahrenheit or 40.5 Celsius. Temperatures this high cause multi-system organ failure due to proteins becoming denatured. It's like frying an egg. The temperature causes the egg to change from liquid to solid and the color to change because the proteins are denatured as you cook it. The same thing happens in the body at high temperatures. However, interestingly, antipyretics like Tylenol don't work to lower the temperature. If you need to treat a patient with high temperature, you need to put them in an ice bath or use mist-in fans to cool them and keep their proteins from denaturing. Whatever treatment you decide to use, it should be tapered off slowly because NMS can last for days to even weeks. A slow taper is best at preventing recurrence. After removal of the offending agent, the natural history, meaning without treatment, is that symptoms should improve over 1 to 2 weeks. Interestingly, electroconvulsive therapy, or ECT, has been reported to help, although improvement is reported around the 3rd or 4th of 10 ECT sessions in one series, so it's hard to know if ECT is actually helping or if this is just the natural course of the NMS improving over time. ECT can be useful in patients where it's difficult to tell NMS from catatonia. Does NMS occur after an antipsychotic overdose? These are pretty common. But interestingly, no. It's usually related to subacute or acute exposure. And again, this is in contrast to serotonin syndrome. Some psychiatrists like to treat severe schizophrenia with a depot antipsychotic, a preparation like a shot in the butt that lasts for a month. They find it useful in patients with severe disease that prevents them from regularly taking their medicines. I can tell you from experience, NMS is really difficult to treat after depot antipsychotic treatment because the patient's going to have symptoms for more than 30 days. The hospital team treats with benzos until the patient's fever and altered mental status improve. He's able to move spontaneously with no more muscle rigidity. They elected not to use bromocriptine or dantrolene as he seems to be responding well to benzos. The patient stays in the hospital for over 2 weeks as they titrate the benzos down and cautiously restart antipsychotics, this time using an atypical antipsychotic rather than haloperidol. 2 weeks is actually the recommended time to wait before restarting. This is a fictional case, as are all our cases to protect the innocent, but it is based on real poisonings. That brings us to the last question in today's podcast. What is the risk of reoccurrence with NMS in our patient? A, greater than 90%, B, approximately 30%, C, less than 1%. Follow the Twitter and Instagram feeds, both at PickPoison1 for the answer. Remember, never try anything on this podcast at home or anywhere else. Thanks for listening. It helps if you subscribe, leave reviews, and/or tell your friends. Transcripts are available at pickpoison.com. While I'm a real doctor, this podcast is fictional, meant for entertainment and educational purposes, not medical advice. If you have a medical problem, please see your primary care practitioner. Until next time, take care and stay safe.